Thank you. Thank you very much, and good morning, everyone. So it's a rather difficult question about the common link of the different heat in this entity. So rather than giving a label to the pathophysiology of the disease, we try to guide through and to give some consideration, also some speculation about a common network of damage on the portal tract in this patient. So starting from a possible direct damage to the endothelium of this patient, the most important things are the drugs, so exposure to drugs. And the azathioprine in particular and the oxaliplatin share the same pathophysiological mechanism of direct endothelium damage by the depletion of intracellular glutathione that is most susceptible in the endothelium rather than the hepatocytes because of the different concentration, but also oxaliplatin has a direct cytotoxicity and increase of free radicals damage to the endothelium, and everything is leading to the sac detachment, the loss of the barrier integrity and exposure of the subendothelial matrix, increasing the platelet adhesion and the microthrombus formation, with also the production of large von Willebrand factors and other angiogenetic profactors in the endothelium subset. And also in HIV, as you already heard by Filippo Neri, there is a possible correlation with exposure to different drugs with different pathophysiological mechanism, from the increase of oxidative stress, the decrease of enos, the increase also of adhesive factors in these patients, or the direct endothelial activation, leading all to a prothrombotic and a dysfunctional endothelium in these patients. And also HIV per se can cause, due to the persistent inflammation, probably the persist increase in pro-inflammatory cytokines, immune activation, and also in some patients gut barrier dysfunction, to an activation of the endothelial cells with senescence, exposure of VCAM, ICAM, microthrombosis, and sinusoidal capillarization. So we can see in some patients, PSVD and non-cirrhotic portal hypertension with and without drug exposure, in this patient with a direct endothelial damage. And another toxic agent that is less common in our country, but has been recognized as a direct endothelial damage agent, especially with intake by water, contaminated soil, or traditional medicine, is arsenic exposure, which is causing an activated NADPH oxidase NS2 with superoxide oxide with stress radicals produced, which are also exaggerated by an iron overload in the cells, leading to a defenestration, primarily a capillarization of the sinusoids with a secondary inflammatory setting in this endothelium, leading to activation, angiogenetic, and prothrombotic phenotype. Bacterial translocation, for example in HIV and other subsets, has been recognized as another factor activating immunological damage in the endothelium. Since many years ago, it has been shown that infusion of E. coli in the portal vein was able to cause scattered infiltration of mononuclear cells and proliferation of epithelial cells in the endothelium, the portal vein tract, and granulomatous aggregates, especially in the mid-size portal venous tract, and in the long term, stenosis of the portal vein branches with the proliferation of collateral branches similar to pre-SPD. And recently, localization of TLR4 receptor, which is mostly linked to the activation of lipopolysaccharide in the liver biopsy, have been found in a patient with PSVD, with and without portal hypertension, associated also with the increase of LPS in patients without portal hypertension as well, and zonulin, which is a marker of impaired gut barrier permeability. However, some patients without portal hypertension in this cohort had primary immunodeficiency, which I will show to you that are linked with the dysbiosis and gut permeability dysfunction. But the gut-related drivers due to the dysbiosis, the increased permeability, and the metabolites of the microbiomes can cause, with various mechanisms, endothelial damage directly from the intestine through the portal vein, giving a prothrombotic and pro-inflammatory phenotype of the endothelium. And this can happen as a condition superimposed to the associated condition that we find in patients with PSVD. And a human model of that are the primary immunodeficiencies, in which we have especially correlated with the reduction of the B memory cell in the spleen and the absence of secretory EGA in the intestinal epithelial cell, a direct intestinal immunity and mucosal permeability associated with a risk of bacterial infection and an increased translocation. And in fact, about 1/3 of the patients with primary immunodeficiency and non-cirrhotic portal hypertension show in the intestine characteristics similar to celiac disease, with atrophic villi and infiltration of mononuclear cells and immune cells in the epithelium of the duodenum. But for example, in inflammatory bowel disease, in which we can see PSVD and cirrhotic portal hypertension also without the risk factors of azathioprine in this patient, the continuous bacterial translocation for the damage of the intestine, along with the recurrence of acute inflammation and acute translocation from the intestine of bacteria, but also pro-inflammatory cytokines, can cause endothelial damage. Because when it has been shown that there is an acute manifestation of IBD, you can find a CT scan, the scattered appearance of the liver, which is histologically linked to sinusoidal dilatation. Because pro-inflammatory cytokines can be on top of the translocation mechanism, especially in IBD, because they can drive endothelial activation, and they can be integral in the progression of PSVD and contribute to portal hypertension. It has also been shown, for example, in this model given by the COVID infection by our university, in which IL-6 was able to produce pro-inflammatory and procoagulant genes in an LSEC through JAK-STAT pathway. But the endothelium can also be activated and damaged by a direct immune damage. We know that the most important antibody recognized associated with PSVD immunological disorders are the anti-endothelial cell antibody, which have been shown to be with immunofluorescence located especially in the portal venous tract, and with the direct link to heat shock proteins, which are in these band regions, which are the most sensitive cells during apoptosis and damage, and can be easily expressed and targeted by the AECA, with increased leukocyte adhesion, inflammation, and amplifying apoptosis. And and the deposition of elastin during these antibodies is along with the expression of CD54, so along with the portal venous tract. And the exposure to the serum of patients with PSVD, but not cirrhosis, was able to increase the expression of elastin in the endothelial cells. And this was correlated with the concentration of antibodied anti-endothelial cells, and with the associated increased apoptosis of these cells. So these antibodies are leading to endothelial activation and dysfunction with an increased expression of adhesion molecules and also an increased expression of connective tissue growth factor and production of extracellular matrix deposition. On top of that, in some autoimmune disorders, we have also an increased systemic inflammation that is increasing endothelial damage and leading to endothelial to mesenchymal transition, which is an important mechanism that we show in this disease as well. In another immunological disorder, which is systemic sclerosis, for example, the TGF-beta and connective tissue growth factor pathway is the most important pathogenetic factors for the deposition of fibrosis in this disease. And it's also important inside the liver when we see PSVD, because HLA, DR antigens can be present also on the endothelium, the portal tract, and can be targeted by the immunological disorders, leading to the same pathway and so endothelial to mesenchymal transition. So moving to this kind of question, is a really primary thrombotic disease? We see these disorders with a very different correlation with thrombophilic genetic condition compared to other vascular liver diseases. And the association is primarily with antiphospholipid syndrome, prothrombotic disease, and myeloproliferative diseases, actually as a frequency of that. But also, as was mentioned by Felipe before, antiphospholipid syndromes, aside from being a prothrombotic disorders, is also an endothelial disorders, because this kind of antibodies can promote the activation of this pathway with the decrease of NO, so vasoconstriction, the increased adhesion of monocytes with increased production of tissue factor in endothelium, increase of adhesion, increase of activation of complement with increased tissue factor as well, and more produced of microparticles by the endothelium. So it seems to lead to really an endothelial disease that is driving to a prothrombotic, that phenotype of the endothelium. And also myeloproliferative diseases target the endothelium in a specific way. There is systemic prothrombotic condition with also pro-inflammatory pathway, but there is also expression of JAK2 mutation inside the endothelium with an activated netosis, increased adhesion molecules, increased expression of von Willebrand factor, and also a shear-related damage due to the increased thrombin and increased microparticle in this patient. So it is a prothrombotic disease, but it's also an endothelial-related disease that can cause PSVD. And we can also consider the role on the spleen itself in myeloproliferative disease. Why? because it can produce a lot of TGF-beta inside the portal vein. And also, when you have a massive spleen, it changes also the INOS production. TGF-beta pathway is very important in myeloproliferative disease because the overproduction by the megakaryocyte and the myeloid cells leads to activation of fibroblasts, excessive extracellular matrix deposition, and is contributing to myelofibrosis in these patients. But this prothrombotic environment and profibrotic environment can extend to the vasculature, the hepatic vasculature, because it can be transmitted from the spleen to the liver. And that can activate the SMAG signal leading to endothelial to mesenchymal transition. And for example, in these patients with PSVD, the CTGF was really, with in situ hybridization, really much more expressed in patients with non-cirrhotic portal hypertension rather than cirrhosis, and it was expressed in particular in the epithelial cells of the biliary tract along with the portal vein, but not inside the endothelium. And it was correlated also with the systemic levels of CTGF in patients with non-cirrhotic portal hypertension, which are more than patients with different chronic disease or cirrhosis. And the change of phenotype of the cells losing CD34 and acquiring the SMAD2 pathway, it's increasing in the non-cirrhotic portal hypertensive patient very much compared to cirrhosis. And it is correlated with a higher level of TGF-1B and the loss of the control-regulatory mechanism of the BMP7. So this is a possible mechanism contributing to the portal venous stenosis in this patient. And also the TGF-beta along with endothelin-1, which is produced also in portal hypertension, which is not contributing so much in cirrhosis, can further contribute to the total production of extracellular matrix in this patient. And endothelin-1 is particularly stimulated in the spleen when you have translocation, for example, from the gut. So everything can be circular and potentiated. And also INOS and ENOS are different from the spleen in patients with non-cirrhotic portal hypertension. Probably is not reaching the liver itself because the half-life is 5 seconds, but can be responsible to the wide dilatation we see, especially in the portal venous and the splanchnic system of this patient with non-cirrhotic portal vein thrombosis compared to patients with cirrhosis itself. And targeted the spleen with splenectomy has been shown like 30 years ago to decrease the production of pro-inflammatory cytokines when there is exposure to LPS. Also, genetic network analysis confirmed that in biopsy of patients with non-cirrhotic portal hypertension, PSVD, that there is a specific pathway of some genes correlated with the deregulation of vascular injury, endothelial cell dysfunction. Systemically, if we look at that by extracellular vesicles that we are working on, and looking at an endothelial derived cells, the platelet-derived cell, with activation of immunity in patients with and without portal hypertension of different associated conditions, we can see that there is a clear activation of the endothelial derived cells, both in patients with and without portal hypertension, with specific lesions that were specifically or with OPV, which show release of intact, activated, and activated prothrombotic pro-inflammatory microparticles from the endothelium of these patients with, again, in patients with or without portal hypertension, an increase of activation of the platelet generally, and activated platelet with less activation of the leukocyte and monocytes. So immune-activated cells able to scavenge the mechanism pro-inflammatory have a prothrombotic, with some resistance to protein C, which can be seen also in patients without portal hypertension, despite a normal protein C concentration in comparison with patients with portal hypertension. Clearly some decreased function of protein C. So we can integrate the pathophysiological model, saying that there is, in many of them, most of them, an endothelial activation and a profound vascular dysfunction, which is called a different damage, different hits, and associated condition. It is leading to a chronic endothelial injury, which is also shown with the shedding of this marker from the endothelium, which is a marker of TGF-beta pathway activation anyway. And also, it's likely that the immune suppression that we can see with the microparticles can be due to some immune checkpoints molecules that are shedding from the endothelium. And the shedding of the PCR receptor can be responsible also for the protein C resistance we see. And there is a crosstalk between the coagulation, the immune system, and the matrix modeling that can be lead to the platelets activation as well, the procoagulant, tissue factor, endovesicles, and the skewing immune activation that we can see that is decreasing the remodeling without taking out the prothrombotic phenotypes molecules. But we're sure that it's not conclusive. It's quite a speculative talk, of course, and more will come from most of you in the panel. Thank you.
Congratulations. One question. Have you taken into account the associated conditions when you evaluate, for example, these vesicles, to see if the vesicles you found with all these markers are similar, or it depends on the associated condition if there is autoimmune? Because then you may think about, is really the PSVD or it's really because of the autoimmune? Have you taken into account that?
It needs more number, and so we are collecting more samples from 2 centers, from Barcelona and from Paris. Actually, in those small cohorts, there were more endothelial microparticles in patients with myeloproliferative disease, for example, compared to other etiologies. But actually, we need more to divide due to the heterogeneity of the condition. You need more numbers, and we will do that.
Since endothelial dysfunction is in the central of the pathophysiology, do you think that we have enough data to think further and thinking on the treatment for stabilizing the endothelia, like the simvastatin?
I'm happy that Pier Emanuele will respond to that.